Welcome, everybody. We'll just give folks a few minutes to log in and then we'll get started.
For those of you logging in or logged in, we'll get started in a few minutes here, okay?
We still have some folks logging in, but I think given that Dr. Chen has a good lengthy presentation for us today, we may get started.
Okay, so I will go ahead and kick this off then. So welcome everyone. Thank you all for joining. Just a couple reminders before I introduce Dr. Chen and turn it over to him. So this is Research and Discovery Ground Rounds, which is offered as part of the Frontiers CTSI. If you are not already a member of CTSI, please make sure that you join. The address is at the bottom of this slide here. And becoming a member will ensure that you have access to all of the communication happening within Frontiers and you do not miss any of the events that are happening. Our next Research and Discovery Ground Rounds will be on Thursday, April 18th, and it will be a session led by Linda Collins and Jillian Strayhorn, who, for those of you who do not know them, they are leaders in the field of intervention optimization, and in particular the multi-phase optimization strategy MOST. And they will be speaking on MOST and how that applies to implementation science. Okay, so with that, I'm going to go ahead and introduce our speaker for today. So I'm pleased to introduce Dr. Ron Chen, who is a radiation oncologist who's internationally recognized in the field of prostate and bladder cancer. Ron also has a passion for patient-centered outcome research, where he's particularly focused on research that is meaningful to the patient and patient outcomes. And he is also the Associate Director for Health Equity at the KU Cancer Center. And today he's going to be speaking to us about the Cancer Center and how it looks at the bidirectional nature of research and how that research defines its impact on the catchment area. With that, Ron, I'll turn it over to you.
Yeah, great. Thanks, Nikki. Appreciate the introduction and appreciate the opportunity to speak at the Grand Rounds today. I'm going to share my screen. There's a lot of material that I want to share with you, but what I really hope to be able to accomplish is hopefully by the end of the session, I want you to come away with saying, wow, the KU Cancer Center really does a lot of activities that are community driven. We really assess the needs of our community, and that really drives a lot of the research and other activities that we do. And so that's really the theme of this talk. And so addressing needs of the catchment area. There's also some terms that not everybody here is a Cancer Center member, and so there's some terms that I'll start with defining before I get to the bulk of the material. And the first term I'll define is catchment area. So I think people do know that the KU Cancer Center is a NCI, National Cancer Institute. We're an NCI designated comprehensive cancer center. And so a lot of things that we do, catchment area, community engagement, it's defined by the NCI. And so as an NCI designated cancer center, we apply for a grant every 5 years, and if we get the grant, we're NCI designated. And in that grant RFP, it defines some of these terms. So what is a catchment area by the NCI definition? Well, a cancer center's catchment area is a self-defined geographic area that the center serves or intends to serve in the research that it conducts, the communities it engages, and the outreach it performs. So we define an area of communities that we really serve. And it has to include the area from where the cancer draws the majority of the patients, but could be beyond that and has to include the area surrounding the cancer center. So that's catchment area. And I think of it really is a KU Cancer Center has defined a community and the population that we serve with all of our activities, research, outreach, education, et cetera. And our catchment area is the state of Kansas and also 18 counties in western Missouri. So for the rest of this talk, when we're talking about catchment area needs, communities, and what we do, this is really what we've defined as our the people that we serve. And now we include the entire state of Kansas because we are University of Kansas, and with that comes with responsibilities of serving the entire state. And of course, we include Western Missouri because of where we're located and really the area that we draw a lot of patients from in Western Missouri as well. So our catchment area, including these 123 counties, has about 4.5 million people. About 93% of patients we see here at the Cancer Center come from this catchment area. And so how does the cancer center serve this entire region? And I'll talk about that for the rest of this talk. Education, outreach, clinical trials. How do we reach this entire area is really a charge that we have to solve. Of course, people know that a lot of our catchment area is considered rural, and that of course comes with particular challenges related to cancer care and outreach. The other thing that I want to define as a start is community outreach and engagement, and COE. And so as an NCI designated cancer center, we are charged to do community outreach engagement for our entire catchment area. And this is actually the part of work at the cancer center that I oversee. And so what is COE? What do we have to do per NCI, and what are we doing? So NCI designated cancer centers are expected to perform research of particular relevance to our catchment area. So we do cancer research, but we really need to do cancer research that are relevant to the region that we serve. We should engage populations within the catchment area in the research that we conduct. So we need to engage our communities and focus on research that really makes an impact in our area. So catchment area is emphasized here. Actually, and to facilitate this, cancer centers need to thoroughly analyze demographic and cancer burden of the catchment area. So we have to understand, we have to have data to really know what cancers have the biggest impact where we are. In addition, centers expect to engage communities within the catchment area to decrease the cancer burden, particularly among minority and underrepresented populations. And to facilitate these activities, cancer centers have to establish community advisory boards and partnerships with other health care delivery system and state community agencies and coalitions to disseminate evidence-based findings. So this is what we're charged to do as an NCI designated cancer center. Look out for our catchment area, analyze data so we understand the burden where we are, engage communities, look out for disparities, and establish community advisory boards to drive our activities. So the rest of this talk will be focused on these things and what we're doing. And I would categorize our COE activities in these different buckets, which happen to be essentially our specific aims for the NCI grant. So we have activities related to using data to monitor the cancer burden and needs in the catchment area. We collaborate extensively with community stakeholders to inform everything that we do at the Cancer Center. And we use these community needs to then drive the research that the Cancer Center does to address high priority cancers relevant to the catchment area. And then we do a lot of other activities really with the eye to reduce cancer burden in our region. And so And of course, this is a lot of work. For the rest of the talk, I'm going to give examples in each of these different categories, examples, because we do a lot. In 50 minutes, I'll just give you examples and highlights of some of the things that we do in each of these areas. And it's a lot of work, so we have really a big team at the Cancer Center to help facilitate this work. Many of you may know about the Masonic Cancer Alliance, and this is really the staff that do a lot of our COE work, and we have full 18 FTEs supporting these activities. Okay, so I'm going to go through each of these areas and give some highlights to illustrate the activities. And so bucket one, data to monitor cancer burden needs so that we understand what we need in the catchment area. We have great support from biostatistics, and we have great analysts on the team to help us look at these data. And one thing that the Cancer Center was able to create was basically a platform called Optic, Organized and Prioritized Trends to Inform KUCC. And Optic is basically a data warehouse that basically pulls a lot of different data sources into one central area so we can analyze and manipulate, so then we can look at trends that inform our needs in the cancer related to cancer. So some of the data sets are dumped into Optic for us to be able to analyze. We have cancer registry data from both Kansas and Missouri. I'll show you some examples of what we're able to look at. We look at vital statistics, so mortality. We look at some health behaviors that are relevant to cancer, and then some sort of regional area social demographics. And there's more data sets that we're adding to this all the time. But with this pool data resource, we're really able to create some tables and figures so that on an annual basis, we can look at the trends in our catchment area and then try to prioritize our activities. So in our catchment area, we have about 4.5 million people. We have many counties that are considered rural, and that actually makes about a quarter of the population, so over 1 million rural residents in our catchment area. We have about 8% of our population is Black, 11% Hispanic. We do have almost 10% of the population who do not have health insurance. Again, looking at data to sort of look at the needs of our area. So on a regular basis, we look at what are the biggest cancers that impact people in our area. And so we look at men and women. Incidence is basically the diagnoses, and then mortality are the cancers that cause the highest death rates in our region. And we look at Kansas and 18 counties of western Missouri. And so these are the top 10 cancers by incidence for men in our region, and here are the top 10 cancers for women. And then again, a lot of data that we look at all the time. And then we also highlight some of these rates and incidence and mortality where we are in our region higher. We have higher rates of incidence and mortality in some of these cancers, higher than the US average. And so in my work and our work in COE is to look at some of these epidemiologic data, and we say, well, this is pretty high. And then what this could do is then drive our researchers to then look into why. So I don't know why, but this highlights areas where we have opportunities to do research to understand why, and areas we can do research to then potentially try to reduce some of these rates. And so this is what we look at on a regular basis. We also look at disparities. We know that in many cancers, there's disparities related to mortality rates. There's racial disparities. There's disparities related to if people live in rural areas, they may have less access to cancer care clinical trials. And so we are also able to, with the help of Optic and our data analytic team, look at cancers where there's higher mortality rates in certain patient populations. And again, we look at these data and then we sort of use this to try to drive some of our priorities and work. So in our catchment area specifically, we have a 70% higher mortality rate in prostate cancer in Black patients compared to white. And some of these other cancers, 60% higher mortality, 30% higher mortality. So there's Black-white disparity in mortality rates in our catchment area in some of these cancers. There's also disparities with Hispanic patients compared to non-Hispanic patients. And then we have some cancers where there's higher mortality rates in rural versus urban patients. Another area of data that we look at are some of the behaviors that may contribute that really are relevant for cancer. So, of course, I think we all know that smoking is one of the major causes of cancer. So we're able to look at smoking rates in our area, Kansas and Missouri, and we can actually look at smoking rates by different groups in our population, race, ethnicity, and our rural individuals. And so we look at this and go, well, there clearly is some opportunity for us to reduce smoking rates in certain groups, and we can compare our rates to the US average of 14%. Obesity is an increasingly important behavior and issue for cancer. Obesity is actually associated with at least 13 cancers, and there's a projection that obesity actually may become the #1 cause of cancer in the nation, overtaking smoking in the future. And we look at this and say, well, we do have an opportunity to reduce this across all different segments of our population that's higher than the US average. And we can look at cancer screening rates. This is colorectal cancer screening, but we can look at other screening rates as well, and we can compare how our screening rates are compared to US. So we look at cancer incidence mortality, we look at disparities, we look at risk factors and behaviors, again, to drive some of the emphasis that we do, of work that we do at the Cancer Center. But we don't do this alone. We really do this in close collaboration with the community. If we think that there is opportunity or an issue in our catchment area, we really have a culture where we want to work with the community to design interventions and research and studies, because really with that kind of collaboration, we can then formulate probably the most effective interventions with a best uptake. So a lot of what we do and what I'm trying to communicate in this presentation are the extensive collaborations of the Cancer Center and community members to basically drive these activities. And so what we have at the Cancer Center is that we have formed a community advisory board. The community advisory board currently includes 20 individuals that come from different parts of our catchment area. Again, we're trying to serve the entire state of Kansas. We're trying to serve Western Missouri, and we want the community representation to not just be from Kansas City. So we really have taken a lot of work to try to find individuals who are willing to serve on the community advisory board, to advise on activities from different parts of the catchment area. And also we want representation of people who have different cancer experiences. We have some cancer survivors who have had cancer. We have people who have taken care of family members with cancer, kids or adults, family members, and have those experiences. We have people who have friends with cancer. And so diversity of cancer experiences with different community connections, live in different parts of our catchment area, diversity in terms of culture, race, ethnicity, and gender. So 20 individuals form this community advisory board that meets 4 times a year, and they directly advise Dr. Jensen, our Cancer Center director, and our Cancer Center leadership in all the activities that we do. In addition to this community advisory board that directly advises Dr. Jensen, the Cancer Center also has an extensive network of community collaborations throughout our catchment area. It's really hard to actually reach some of these areas, counties that are rural and frontier, that are far from Kansas City. But this map shows you really the emphasis that we place on extensive community collaborations to really help us understand the needs of communities and also help drive our activities and collaborate. And so some of these community collaborations include these yellow dots. It's a consortium called the MCA Network. MCA Network includes cancer programs, community hospitals, and other organizations that collaborate with us. K-Pepper is a group of primary care practices. And now, in some of these regions of our state, may not have access to a cancer program locally, and primary care is another way for us to be able to make an impact and reach some of the cancer patients and provide services. So we also collaborate with a group of primary care practices throughout the catchment area in research, education, other activities related to cancer. Pivot, I'll describe a little bit later, but Pivot are basically community members and some of our patient advocates who have volunteered to collaborate with our researchers. So we have a large group of community members who say, hey, I would love to collaborate with your researchers to help inform them about research and tell them what really is important to patients. And so we collaborate with community members on research. And then we have a variety of other partnerships throughout in different activities that we do. So Community Advisory Board drives our activities. A lot of other activities that we do are directly informed by all of this extensive collaboration through our catchment area. Now, I want to give examples of how the community drives what we do at the Cancer Center. So these are just some examples. Again, there's a lot that we do. These are just 3 examples for the time. So one of the major things that we do at the Cancer Center is that we provide free cancer screening throughout the region, not just in Kansas City. We go everywhere throughout Kansas and Western Missouri to really provide screening events in local communities. And on a yearly basis, how we select where we go to do cancer screening, these locations are selected by the Community Advisory Board members and by our network sites. So we have some ideas of where we think needs screening, but really the community helps drive the places that we select to go for screening every year. We also, the MCN network, which again, smaller cancer programs, community hospitals, other organizations, and the primary care K-Pepper network, they help tell us what kind of education and CME needs that they may have. And that really helps drive some of the activities that we plan to meet these needs. And then in the past couple of years, we started a grants program where community organizations from throughout the catchment area on a yearly basis can submit applications for community grants. And I'll show you some of these examples, but this is also another way where communities tell us what their needs are, and then we review those grants for cancer-related programs, and then we fund 2 or 3 of those each year. And actually, again, the selection process is finally selected by the Community Advisory Board. So we really have community input on their needs and a community selection of grants that we fund. So all of these are just examples where community really drives many of the activities that we perform at the Cancer Center. So next slide just shows some of the grants that we funded to the community. And again, we do this every year. So there was a community grant from the Community Health Center Southeast Kansas, and what they proposed to do is to develop a program to increase lung cancer screening rates. Lung cancer screening is really low in some parts of our catchment area. They want to do something to specifically increase that in Southeast Kansas. We thought that was very worthwhile and funded that. A group called Concerned Clergy of Kansas City wanted to develop a prostate cancer prevention education campaign and do a communities assessment. And this specifically also impacts the African-American men in the area. And so that was one of the grants that we funded. Gilda's Club is a great organization here in Kansas City that provides free services to cancer patients and survivors and families. They do a lot of services, but one of the things that they do is they have a cancer survivorship program that's geared toward helping patients transition from the end of treatment back to a normal life. So cancer transitions program. And that's been very successful. They want to make this a virtual program so they can expand access and offerings to 8 additional areas in Kansas, Missouri. We funded that program. Johnson County Mental Health Center submitted a grant that said, hey, in individuals who have a mental health diagnosis, often cancer screening is neglected. So they want to create a program that increases cancer screening in individuals with a mental health diagnosis. That we felt was a need and funded that. And then a program in Hayes that wanted to develop an education program to reduce vaping in middle school children. And so these are some examples. Again, community tells us what their needs are. They want to develop a program. Our community advisory board said that these were worthwhile, and these are grants that we funded. And again, we do this on a yearly basis. Another really important aspect of NCI designated cancer centers is looking at our catchment, looking at the cancers that really have the biggest impact. NCI cancer centers have to designate certain cancers as priorities to drive the focus of their work. And this doesn't mean that if it's not on the priority list for what we form, we don't do research. But this list really does address the highest priorities in our region. And this really, when we do research, when we do outreach, when we do education, we are always keeping an eye on whether what we do has an additional emphasis on this list of priority areas. And looking at the data of our region, in discussing with community and community advisory board, and we do this on an every 5-year basis. In the current cycle, this is a list of our current priorities. Tobacco-related cancers, we do have, continue to have a tobacco problem in our catchment area, and lung cancer continues to be the #1 cancer in incidence mortality. And so that was felt to be a really important priority. Prostate and breast cancers are #1 in men and women in our catchment area, highly relevant. GI cancers like colorectal and liver have high mortality rates in our catchment area. Heme cancers like lymphoma, leukemia, also really high mortality rates. And so these were felt to be the cancers that really represent the biggest opportunities for our activities in this 5-year cycle. And also obesity was chosen because of that issue in our catchment area, really relevant to all segments of our population. So again, in working with our community advisory board, this is a list that's felt to be the highest priority of the concerned activities. We also have a special emphasis on watching out for our rural population because of how big of a segment that is in our catchment area. Okay, so the next section, I want to give examples of how these priorities, our catchment area, and the community collaborations really then help drive the research that we do. We do a lot of great research, and we do a lot of great research anyway, but really I want to emphasize how the community drives some of the research activities of what we do at the Cancer Center and the collaboration, how important the collaboration is. One of the things that is really great that we have at the Cancer Center is a group called PIVOT. PIVOT stands for Patient and Investigator Voices Organizing Together. But what this really is a group of 158 community members who have said yes to wanting to collaborate with our researchers. And so again, what I mentioned before, these are people who live in different parts of our catchment area, not just in Kansas City. Some people have had cancer themselves. Some people have not had cancer and really just want to be able to collaborate to drive cancer research. And they're a diverse group of individuals who have volunteered to be able to collaborate. And this has been a really successful program. And what you can see is that in the years where we've had the PIVOT program, the Cancer Center, there's been at least 77 researchers at the Cancer Center who have collaborated with these community members in PIVOT. The Cancer Center has 3 dedicated research programs: cancer biology, which is mostly basic bench research, cancer prevention and control, and D3T, which is translational. But what you can actually see is that all researchers from all 3 programs, even the bench researchers, have found opportunities to collaborate with community members to be on their research team. And this collaboration has led to more than 70 grant submissions in collaboration between research teams and the community collaborator. So that's been really great. And lots of papers have been published, grants have been funded. This has really been a great collaboration. And now sometimes, new researchers say, well, how do I tap into this? How do I get into finding pivot members who can help me with research and collaborate? And we have a mechanism called Rapid Reactor Panel, or somebody may say, well, I want to collaborate with a research advocate. I have a grant deadline in 3 weeks. How can I get a rapid feedback and collaboration from Pivot? So we have a mechanism called Rapid Reactor Panel. A researcher can just reach out to us and say, I need to have a Rapid Reactor Panel session. And based on the type of research, breast cancer, prostate cancer, whatever, we will use some of that information to match about 5 Pivot members. Then we will have a Zoom session where the researcher is able to basically talk about their research, and then you get rapid feedback in a 1-hour session from these community advocates, and then you can form a collaboration. And oftentimes this first Rapid Reactor panel session may actually lead to a longitudinal collaboration, sometimes over many years, grants and papers and abstracts and presentations. And so this has been a really great program. And again, a way for the community to really help inform the research at the Cancer Center. I want to give several other examples of how the community drives the research of our cancer researchers. And so I talked about the catchment area priorities, GI cancer, breast, lung, smoke, tobacco-related cancers. These priorities, which really are based on the needs of our catchment area, this really is important, and we communicate these catchment area priorities to all the research program leaders at the Cancer Center, and actually we communicate to the entire Cancer Center membership on a yearly basis. So we say, these are our current priorities. When you think about research projects, see if you're able to address some of these priorities, which have the biggest impact to our population here. We actually have the 3 research program leaders present to our community advisory board every year. I think the community advisory board really is interested in updates on the research that we do at the Cancer Center, and also this opportunity for direct community feedback to drive future direction for our research programs. The pivot that I just described, 100 and some community advocates, they're actually review our Cancer Center pilot grants. And so we have pilot grants every year. The pivot advocates actually are part of the review process and help us really decide which grants are funded in the end. And then so clinical trials, investigator-initiated trials, where we're designing clinical trials, pivot advocates also have a role in reviewing those, providing feedback in clinical trials as well. We already talked about how pivot advocates meet individually with researchers for collaboration. And then this is such an important part of our culture. Every year at the Cancer Center Symposium, which is multiple days, 1 day every year during the symposium is actually dedicated to highlighting pivot and the researcher community collaborations. And we even have some of these pivot advocates do some of the presentation and to highlight that. And so again, part of our culture that we're going to continue to emphasize as part of what we do every year. I also want to show how community engagement helps with clinical trial at the Cancer Center as well. People know that the Cancer Center is in Kansas City. I think people know that clinical trials often represent the opportunity for patients to have access to the latest, maybe really promising treatments, but not everybody who lives far from Kansas City is able to come to Kansas City to enroll in clinical trials to have access to these options. And so what's happened in order to address this problem and in order to basically serve our entire catchment area, the Cancer Center formed a network called the Amazonic Cancer Alliance Network. And so we collaborate with cancer programs, community hospitals, other organizations. And what the MCN network members can do is that they're able to offer clinical trials we have at KU to patients in the community, and people can actually stay closer to where they live and have access to some of these clinical trials. I think that's really great. And what we can see on this map is that we actually, because of the network and because of other efforts, we actually are able to have patients from almost every county in our catchment area enroll on clinical trials. And so I think that's really great to be able to extend the access to clinical trials for patients who live far away from Kansas City. Uh, um, and because of our success in this effort, we were able to get an NCI grant called an NCORE grant, and we're the only NCI cancer center in the country to have an NCI NCORE grant dedicated to increasing clinical trial access in rural communities. And we have been working with other cancer centers around the country to share our experience in doing this so that other states can do something similar to increase access. And another thing where the cancer center the COE has done to help with clinical trial access is that an app has been developed, the Clinical Trial Finders app that you can download from Google or Apple. Anybody can download this, and patients can use the app to search for trials that may be applicable to them. You have breast cancer, it's stage 3. Is there a clinical trial available? And not only can patients use the app to find trials that may be relevant, the app can actually take them directly to a cancer navigator if they want to either talk to somebody or be connected with an appointment to think about that trial some further. So I think many of these efforts really contribute to our ability to have patient access clinical trials, and again, an important part for us serving our catchment area. Another issue that we know we have in our region and also nationally is that a lot of cancer clinical trials historically do not have a lot of minority patients enrolled. We have some of the major practice-changing trials, but really with underrepresentation of patients who are Black, Hispanic, and other underrepresented groups. That's a problem, and we really need to increase access and enrollment of representative patients in clinical trials. So that's a problem that's been identified. It really does impact our region. And so what COE has done in collaboration with others is in the past year or two, we created and launched a clinical trial awareness campaign specifically trying to address this issue. And we collaborated with a local minority-owned company called TICO to create this campaign and then to launch it. And what TICO has done, which is really great work, is we didn't want to design this campaign without community feedback. So TICO helped us get community feedback. They did a community survey of over 600 individuals to assess current attitudes about clinical trials. And again, in this particular sample, we see that, maybe 2/3 of the people have a positive impression of clinical trials, but about a third were not sure. And so I think that gives us some information as we create this campaign. And then what they also did is TICO helped us talk to individuals in the community so that we better understand what some of the concerns and barriers are to clinical trial accrual. So they did focus groups talking to Black individuals, Hispanic individuals to assess where we are. And now we have a little bit of time, so I'll show you a part of the results from this focus group in the video. And this video is direct quotes, representative quotes from some of these focus groups that TICO helped us do.
Dr. Chen, should we be hearing sound with this?
Great, thank you. And so I apologize that you were not able to hear, but this video still worked because they actually typed the words. And so I'm glad, thank you actually for letting me that you can hear the sound. But I really do think that this is just a representation of, getting direct feedback from the community to understand. And I think this really illustrated concerns, barriers, maybe lack of trust that helps us to then design the campaign to address some of these issues and barriers to enrolling in clinical trials. So I'm going to the next slide. So this slide also summarizes some of the themes from the focus groups. And that helped us design the campaign. And for, I think, some of the important themes that came out, if we were designing a campaign, the messages need to be bilingual to be able to be receivable by the Latinx community. Makes a lot of sense, but really, I think it's really important for us to understand that. Maybe we should use less medical terminology in a campaign to the general community. People want to understand how clinical trials affects them personally. There's a concern about lack of representation of people who are medical professionals. There's a trust issue, which I think we heard about as well in the video. Some concerns about cost. And so, again, getting community feedback to then drive how we are able to then create a campaign. So unfortunately, if you're not able to hear sound, then you may not be able to hear this ad because this ad is actually not. But in any case, I think it's okay. I will skip the ad, but what I will show you. What I will show you is without sound. I think I'll just run a few seconds of the ad to show you can sort of just visualize and try to see how the ad was also created without hearing words, how that may be able to try to engender some trust in talking about clinical trials, maybe think about enrolling on it. And so I'll play a few seconds. You can't hear, but you can sort of at least visualize and try to see what the ad looks like. So some of the words that were spoken, again, from people who are directly involved, survivors, clinical trial participants, some of the words that were used is, I wouldn't be able to get the treatment that I get today if somebody else didn't do clinical trials before me. And so it's sort of talking about the impact of how that's relevant because other people participating in trials that led to the treatment that affected me. And so I think really great words from people who were directly involved trying to tackle some of the concerns that were expressed in the focus groups. And so this campaign, including that video, really multimedia. There were radio ads, La Mega and some of the other radio stations, Telemundo commercials, printed ads, social media, billboards, really multimedia to try to reach a population to get some of these messages across and to raise awareness. And you will also see some of the pictures and creatives that really came out of this. And here's an example of a billboard that was put up with a lot of views that were able to sort of assess as at least part of assessment of impact. So community engagement, tackling a problem, clinical trials research, driving what we do at the Cancer Center. So in the last few minutes, the last part is to talk about other activities the Cancer Center does throughout our catchment area to try to reduce cancer burden in our entire area. A part of what I mentioned before is that we do a lot of free cancer screenings. People know that early cancer detection is important as the best way for long-term cure and survival. A lot of people may not have great access to screening or may skip it. And so in the last 5 years, the Cancer Center has conducted free cancer screenings throughout the region that impacted people from 90% of all counties in our catchment area, including some of these rural frontier counties, reaching over 4,000 individuals in the last 5 years. There is the Cancer Center runs a program called Pool Cool. We have basically staff that go to swimming pools throughout the region. And what they do is a education program about sun safety and using sunscreen to prevent skin cancer. And we have been able to, in the last 5 years, hundreds of pools in the 147 communities. And that includes a COVID era as well. We provide continuing education to health providers throughout our catchment area as another way to make impact. Over 12,000 continuing education hours in the last 5 years. And then every 5 years, we do a catchment survey where we sample the population and we send out surveys to directly ask questions and assess community needs in individuals. And you can see that the last survey that we did had 900 respondents representative of the catchment area, so we can also assess direct feedback from these individuals. And then there is an educational program called Bench to Bedside. Dr. Jensen on a weekly basis hosts Bench to Bedside, and it talks about research, it talks about screening, prevention, it talks about new treatments, really just great education program directly accessible to anybody in the community. This was the Facebook Live series on video. It has transitioned to podcasts, but you can see the reach of over 250,000 views on the Bench to Bedside series, direct education to community people who want to learn more about cancer on a regular basis. I think another part of the impact that we can make in cancer in our catchment area is to impact health policy in 2 states, health policy in different local communities, even health policy nationally can help us drive and reduce cancer burden. So these are just a few examples of health policy that we've been able to impact from the KU Cancer Center perspective. When COVID hit, we advocated for early access of COVID vaccine for cancer survivors when COVID vaccine was in short supply, because cancer survivors represent really a high-risk group of immune compromise and catching and dying from COVID, and we were able to successfully advocate and get that accomplished in our catchment area. And that also addressed the community concern. Survivors told us that that was really an important issue. We helped advocate for Missouri Medicaid expansion. We continue to work on that in Kansas, but Medicaid expansion can drive down the uninsured rate in our catchment area and therefore drive up access to cancer treatment. We've had impact on tobacco policy, increase the age of tobacco, increase access to tobacco cessation medication for Medicaid, and some of the other policies that examples of how we can use this to reduce cancer burden in our catchment area. And then another part of the last part of what we do is we have to measure impact of what we do and impact in our catchment area. And so we look at this all the time. You know, if smoking is one of our priorities, are we making an impact on smoking with all the things that we're doing? And so we have been able to show continuous decreased smoking rates in adults over the last 10 years. So this is, it's hard to tell exactly what we're doing, which activity is leading to this, but we do a lot of smoking research, policy, and outreach, and probably all that together has helped us see that this is less and less of a burden in our catchment area. And then, just my last slide here, we also look at cancer incidence mortality to see if we're able to drive down incidence mortality. And at least an example of lung cancer, in the last 10 years, we've been able to see decreased mortality rates, decreased incident rates, decreased late-stage incident, which probably is because of more screening. And so we look at these data all the time. We have the priorities. We want to see if our activities are impacting these priorities, and this is part of what we do as COE. And I will stop there and really happy to thank you for your attention and happy to take questions.
Okay, thanks, Ron. I saw one question pop up here. Okay, so there's a question that says, I do mostly CAR-T and cellular therapies. Would be helpful if enrollment could be started at a local center. For MCA, can industry-sponsored trials be run through this alliance?
Right. So I think definitely with the MCA network, we can facilitate clinical trial accrual for CAR-T and cellular therapies. Now, if that requires specific expertise to deliver CAR-T therapy, we could collaborate with the network to find patients who may be eligible, but then they may still have to come here if that's the place where there's expertise to deliver the treatment. But so we can still use the network to increase access and awareness and screen for patients in collaboration with these local sites. Can industry-sponsored trial be run through the MCA? That mechanism has not been worked out and a little bit more complicated. I think more accessible would be cooperative group trials that are more accessible through the MCA network.
Okay, great. And then another question, are there any collaborations with the Cancer Moonshot initiatives on both local and national level?
Yeah, we do have some cancer moonshot examples that we were able to get here in the catchment area. I don't have those specific examples at my fingertips right now, but definitely there have been some. And then there's another question earlier. Building an advisory board to serve such a large area took a long time. How open were members to various communities to this type of involvement, and was funding needed? So what I didn't discuss was funding. And what I would say is that because community engagement has been such an emphasis for our Cancer Center, and Dr. Jensen really emphasizes this is an important aspect of KU Cancer Center, there's actually been a lot of funding from the Cancer Center to support these community activities. So the budget for COE and the staff that we have and the collaborations, and we also pay the pivot members and the CAP members for the work that they do, because they have expertise, and even community members, we should pay them for their time and expertise. So this really does take quite a bit of funding, and a lot of it comes from the Cancer Center and Dr. Jensen. And how open were community members to various communities and types of involvement? Some more so, some less. But really, I think we feel it's important. So some community members we continue to engage and help to bring on to collaborate with us. Some were really open and were able to jump on immediately. So.
Ron, this is great. I mean, I'm thinking about, the Frontiers also has a community outreach and engagement core. And, as we're thinking about trying to build more capacity for implementation science and translational work within Frontiers, I think, much of what you're talking about here provides a model maybe for how we can go about that. I also think we need to think strategically about, not duplicating efforts. So anyway, this has gotten me thinking, both with a Cancer Center hat on and a Frontiers hat on in terms, how do these offices with the same kind of name and purpose, how can we work together?
Yeah, for sure. I think there's definitely opportunity to collaborate and for mutual learning. Pivot, which is currently cancer focused, can really be duplicated for other conditions.
Yeah.
And so I think there's knowledge there that if there's will and ability and resources to be able to broaden.
Okay, great. And then we have another question. Does a grant proposal team to have access to the rapid advisory group need to be linked to cancer research?
Yeah.
Or could this group be engaged for other diseases? Okay, good. This is
Yeah, that's a very timely question. You and I
Yeah.
just talking about that about a few
Yeah.
seconds ago. But yeah, so Pivot right now is cancer only and funded by the Cancer Center. But I think there's definitely opportunity to discuss broadening that if there's resources and will to do that in other diseases.
How do you fund your pivot members? Are they paid like a honorarium or how does that work?
I believe that's correct. Like hourly.
Okay. Okay, are there any other questions from anyone else in the audience? I'm just gonna give people a last minute to type if anything. I'm not seeing anything come through.
Great, excellent.
Okay,
Thank you, Jennifer. Yes.
oh, there's an answer. Generally, we're paid, $25 for a 1-hour pivot.
Yeah.
Rapid reactor meeting. Fantastic. Thank you, Jennifer.
Yeah.
Okay, I don't see any other questions coming through. So I want to thank everyone for joining today. And remember that the next session is on optimization interventions, and that is in April. So look for that announcement.
Thanks, everybody.
Okay,
Have a good
thank
day.
you.
Yep.
Yep.